We are the Center for Advancing Health Outcomes, research that transforms care, policy, practice, lives. Visit us at advancinghealth.ca.
Well, thank you everyone for joining virtually today for our Advancing Health Talks Work in Progress seminar on April 2nd. My name is John Erich. I'm the Center for Advancing Health Outcomes Primary Event Coordinator. And I'll just do a quick introduction for you for our session today. I'll introduce the speakers for you who will do, in my opinion, a pretty exciting talk about TB risk in low TB incidence countries. I'm sure it's going to be quite interesting for a lot of you. Dr. James Johnston, one of our speakers today, is a clinical professor of respiratory medicine at UBC and evaluation lead at BCCDC TB services. His research interests include mycobacterial epidemiology, treatment outcomes, drug resistance, and genomics. And Dr. Joseph Puyat is an associate professor at the University of British Columbia School of Population and Public Health, and a scientist at the Center for Advancing Health Outcomes and the Associate Program Director for the Master in Health Administration Program at UBC SPPH. He obtained his PhD in Population and Public Health and his master's degree in Healthcare and Epidemiology from UBC. He also has an MA in Psychology from the University of the Philippines, Diliman. His research focuses on the use of linked large health administrative databases to examine treatment and quality gaps in healthcare. All right, James and Joseph, take it away.
Great. Thanks very much for inviting us. This has been at least for myself, a passion project for at least a decade, forming databases and creating this risk prediction model that we'll be talking about. And Joseph and I have been working for the past 7 years together on this. So this has been quite a long way to this presentation. So very happy to speak about it. We're going to split this talk. I'm going to frame the questions that we tried to answer with our risk prediction model. And then Joseph will be talking about the methodology and how we attack this problem. And hopefully this talk will be about 40 minutes long, leaving a lot of time for discussion and questions. And so we'll try and answer questions at the end for anybody who has any comments there. So, right. Any problems with slide progression? There we go. Okay, so we'll talk today. I'll just frame the questions because there's kind of a broad audience here. I want to make sure people understand why we're asking the questions we are and have the problems we have in terms of TB epidemiology, treatment, and prevention. We'll talk about transmission and natural history because that also helps frame the question. And then Joseph will take over and talk about how we developed this risk prediction model and validated it. In terms of my own conflicts of interest, I have no commercial funding, but I do have operating grants from the following public organizations, and at least for now from the U.S. Center for Disease Control. We'll see if that lasts much longer. And this is really just saying that this is our own opinion. This is not. This involves a linkage of both provincial and federal databases, and this does not represent any of the people involved in those linkages from the federal provincial perspective. So tuberculosis, for those that are not aware, it is the #1 infectious disease killer from a single agent globally. It has unfortunately again surpassed COVID. It passed HIV about a decade ago, and it kills about 1.5 million people per year globally. Some of those people are living with HIV, but the vast majority are not. And a lot of this is due to lack of diagnosis, but also slow to diagnose and then poor outcomes of treatment itself. These mortality statistics do not include the 1 in 50 people globally who are affected by TB who have higher rates of mortality post-TB. The post-TB literature is just coming out now noting that people with TB have much higher rates of morbidity and mortality. And these statistics do not account for that. So in fact, the mortality related to TB is quite high and often under-recognized, particularly in places like Canada, where there's much lower rates of TB. It has a devastating economic toll with 160 billion drained from high-burden countries over the past decade. Why I think this is particularly tragic this is a preventable and treatable disease. So if you look at where tuberculosis is in leading causes of death globally, this disease, many of these diseases are in part preventable. Ischemic heart disease, you take your statin, you have healthy diet choices, but you can't prevent it entirely. And if you go down the list, a lot of these are somewhat preventable, but not entirely preventable. Tuberculosis, I would argue, is entirely preventable, entirely treatable, entirely curable. So it should not be on this list at all. But unfortunately it is, largely because we have not spent the money and time and resources to developing the healthcare infrastructure to respond to this. This is what it looks like recently from the WHO TB report recently published, showing that basically we haven't really had a change in TB rates. We had a small decrease in case notifications related to COVID. That's mainly because gene experts and other diagnostic facilities were taken over to diagnose COVID. And now we've had a resurgence in TB post-COVID. And so despite the UN and the WHO declaring this a global health emergency 30 years ago, and the UN having 2 high-level meetings in the past 7 years on this, we really haven't made huge dents in this. And that's because we haven't really changed our strategy to it. We've relied entirely on passive case finding to try and find TB, which we know that 40% of people with infectious TB actually are asymptomatic. We are not going after TB infection, formerly known as latent TB. So we need to be much more aggressive and comprehensive in our screening programs if we want to have any chance at eliminating this disease, which should have been eliminated a long time ago. Where is TB? Well, for most people who are familiar with TB, you'll know that it largely affects the global south. The highest incidence is in sub-Saharan Africa and Southeast Asia. Sub-Saharan Africa largely driven by lack of diagnostics and the HIV epidemic. To give you some sense of the scope of this problem, in Canada, we have about 2,000 people who have TB disease per year. In the United States, there's about 10,000, 12,000 people who have TB disease every year. In Cape Town alone, just Cape Town has about 30,000 people with TB every year. So this is a huge problem in some areas of the world, including sub-Saharan Africa and Southeast Asia. The incidence is highest in these 2 areas, and also the burden is highest, but I would like to just point out some countries that are particularly affected by TB. So India has 20% of the world's TB, 2 million people. Indonesia also has a very large number of people, over 1 million people with TB. So where there are large populations of people, obviously there are there's a high incidence and burden of TB. But this is actually directly related to our country in Canada, which receives a lot of migrants from some of these countries. And so, if we want to think about this in isolation as a, problem of the global south, I think that's erroneous. I don't think we should anyway, but even if we did, it would be erroneous because this disease can travel and is an infectious disease that can lay in your body for 10, 20, 30 years. And we'll talk about that. So what does the Canadian TB situation look like? Well, we declared it a success actually back in the 60s, really, and have been patting ourselves on the back for a long time for our decrease in TB incidence. And this was largely thought to be related to the invention of TB drugs. So in the late 40s, streptomycin was invented. Isoniazid was rediscovered in the mid-50s, and multi-drug regimens were then put in place. And there was a rapid decrease in TB incidence over the next 40 years. This was coincident with our rapid GDP growth, and disentangling those 2 things is quite difficult, but certainly the invention of TB drugs had a big role, and public health measures such as isolation had a big role. But the story really changes when you zoom into the past decade, and you can see actually our TB incidence and actual numbers are both going up. So you can see that the incidence has been stagnant around 5 per 100,000 for the past decade and has been increasing over time. The absolute numbers also decreasing, not surprisingly, because the Canadian population is increasing. So we would somewhat expect that, with the incidence being the same or a little bit higher. And so we certainly are not meeting our global or objectives of stating that we are going to reduce TB incidence to basically 1 in a million by 2035 or 2050, depending on which metric you use. So we are a long way away from that, and our trajectory is going up rather than down. So we are definitely not meeting our commitments to the WHO and the United Nations to say that we are eliminating TB in Canada. Why is that? So I apologize, this is an older slide, so it's older language. Also, it's an older slide, but I couldn't find a more recent one that showed this so clearly. We have, we have a large population of people who move to Canada from high burden countries. And when people live in a high burden country, they're at risk of developing TB infection, which then you can have in your body for years and decades to come. And particularly with a shift in immigration policy in the 70s, there has been a large increase in the number of people who are coming from high incidence countries. And in turn, we have seen a sort of a rapid rise in the proportion of people who are actually foreign-born who develop TB. And so right now in Canada, about 75% of people who develop TB are born outside of Canada and then move to Canada and develop the disease. When we look at molecular epidemiology, we know that this is actually not from disease acquired in Canada. So people are acquiring this disease outside of Canada and bring the infection with them and then develop the disease due to stress of moving to a new country, due to recent infection, whatever the reasons might be. And so really this is not exclusively a problem of people born outside of Canada, but the vast majority of TB in Canada is in people born outside of Canada. The other people who are largely affected are Indigenous communities, particularly the Inuit, that have rates close to South African rates of 300 per 100,000, so which is, a national shame. And First Nations communities also have a high rate of TB. When we look at Canadian-born non-Indigenous communities, we actually have pre-elimination rates in that group, and so that really isn't a problem. So if we are to tackle TB, particularly in British Columbia, which has a high proportion of foreign-born residents, we really do need to tackle TB in migrants much better, much more effectively. We've been doing the same thing over 40 years, which is screening for active TB, but not looking for latent TB in this group. And that's just ineffective. We need to scale up our strategies to prevent TB in this group. So if we're going to bend the curve, we're actually going to achieve TB elimination in this group. How do we do that? How do we bend the curve? And this is really what we've been spending the last 5, 7, 10 years looking at, saying, like, what can we do differently to actually improve TB rates in this group? Because it's really unacceptably high. So to do that, we have to consider, well, how does the transmission natural history work? So just briefly going over what this bug is and the transmission natural history. So first of all, Mycobacterium tuberculosis is a bacillus. It has a unique thick cell wall, which allows it to grab this pink dye, so it's called acid fast. It grows in oxygen well. It is very slowly growing, doubling time of 24 hours. It has been very well characterized genomically, so we know a lot about it. It has a slow mutation rate of about half a mutation per year in most regions. So what happens is somebody develops TB in their lung, almost always, the majority of time, I should say. And then when that TB starts to affect their lung in a disease fashion, they cough it up or sneeze or even talking, and the mycobacteria goes into the air, and then people inhale it. This is airborne transmission, so similar to COVID, airborne transmission. And one person with TB can infect anywhere around 10 people if it is untreated. So when somebody has infectious TB, a person who is susceptible, enters into this transmission cycle, and they are infected with TB. They get primary infection, and either their body takes care of it and it goes away, or and they have this TB infection, or it resolves, and that's 90% of people. So 90% of people who are exposed to this disease have the infection in their body, or they clear it. We don't know, but they don't seem to be affected by the disease. About 10% of people overall seem to be affected by disease, half of them in the first couple years and half of them later in life. And so so you can imagine somebody who moves to Canada with primary TB infection, especially this group of people later in life, develop disease. And so, well, what can we do to prevent that? So first of all, we need to know what are the risk factors for that. And that includes, so the risk of infection, living in an endemic area, being in a high-risk network, such as the downtown east side, for example, living in a poorly ventilated, crowded area with people with TB disease. Once you have the infection, a number of conditions, including HIV, diabetes, malnutrition, smoking, alcohol use, actually increase your risk of developing active TB disease. So you can imagine that we can have some sort of success in identifying people who are at risk of this by these factors, both their demographic and clinical factors. Okay, so we can identify them. What can we do about it if we do identify them? Well, we have actually TB preventative therapy. So TB preventative therapy is one medication, traditionally for 9 months, but now for 4 months, and actually in some cases maybe down as close to a month of preventive therapy with an antibiotic. We give that to the person with TB infection, and it eliminates TB from the body, basically reduces the risk of active disease entirely. And so we do have a measure that can actually prevent this disease, but we need to know who to treat. And that's really the problem. TB incidence is reduced by 90% with TB preventive therapy. Unfortunately, right now, we don't have a really good vaccine, and this is really our public health intervention. So why don't we just test and treat everyone who enters Canada or everyone who's at risk of TB in general in Canada? Well, most people are at relatively low risk. For example, we have around 200 people born outside of Canada who develop TB every year in British Columbia, but we have approximately 1.2 to 1.5 million people born outside of Canada living in this country. So it really, is a large population to screen and a very small group of people who actually develop TB. And so most people are relatively low risk. And these medications actually have side effects. So, rifampin, which is traditionally what we use, has, hepatotoxicity, it has rashes, it can cause blood problems. So this isn't a benign treatment. About 3% of people have significant adverse events. So if your risk of TB is, let's say, 0.5%, and your risk of adverse events is 3%, it's kind of a hard sell to tell somebody, hey, I know you feel healthy, but we're going to give you this, and it might make you sick, but there's a very, very low chance that you have TB. And most people don't take it. So we need to have, better risk stratification, understand who is developing TB so we can prevent those people with TB and avoid treating the people who have really no risk. And so that is really what our goal is here, is to identify migrants who are at high risk for TB using demographic, such as country of origin, perhaps your immigration status, and clinical characteristics, such as, did you contact TB in Canada? Do you have diabetes? Do you have HIV? And this is a complex interplay between these two sets of risk factors. We could screen people based on country of origin alone. We can screen people based on HIV alone. But that combination of characteristics is really, I think, where the money is to try and figure out who is at highest risk and who is at lowest risk. And that was the goal of this project, was to actually develop a multivariable risk calculator to actually say, this group of people is at high risk, depending on these characteristics, and this group of people is at low risk. And so now I'll hand over to Joseph to talk more about the details of that risk calculation. I'll stop sharing, Joseph.
Thanks, Jay. Let me just share my slide here. All right. So the work that we have done, as Jay mentioned, in the last 7 or to me it feels like 8 years, Jay, have been written up and available for anyone who's more interested in the details. You can find it in the Clinical Infectious Diseases. It was published. It was accepted for publication late last year, but just came out apparently recently. So I'll talk about the model development, how we selected the variables, and how we externally validated it, and then I'll walk you through the working model that we have right now, which is available also online, and that can be used by anyone who's interested in using it. So I'll start off with the data sources. So as some of you may have known, we used linked health administrative data from BC. And these are the different data sources that we linked. We use the vital stats, the data that usually is shared to researchers if you apply to the population data BC. So that's the vital stats, the discharge abstract database, the MSP physician billing, and then we also included the data that sits in different centers, like the BC Center for Disease Control, the renal database, and the provincial TB registry. So we have a total of about 715,000 people that we used for the development of the model. Actually, we have more, but towards the latter part of our work, we decided to restrict the data to certain years to mirror the data available in Ontario, which is the data that we used for external validation. And then for model development, so for model development, we selected the variables that we believe are easy to use or assess clinically, and that have been chosen by a team of experts from different provinces, including BC, Quebec, and Ontario. And we also chose the ones that were that have a strong evidence base. And these variables include demographic variables such as age at arrival to Canada, sex, country of birth or last residence, and refugee status. For exposure variables, we used the TB incidence in the country of origin or country of last residence in the year of landing, whichever was higher. And then we looked at the history of contact with pulmonary TB, which we categorize as close, non-close, and no contact, which represents the majority of the people in our database. We included the comorbid conditions, various comorbid conditions, namely HIV, chronic kidney disease, solid organ transplantation, use of TNF inhibitors, diabetes, steroid use, high-risk disease-modifying anti-rheumatic drug use, and cancer. So these are all the variables that we were exploring, but not all of these made it into our final model, primarily because we selected the ones that we know we can externally validate using data from Ontario. And it's mostly the limitations of the data that we used for external validation. And we have detailed case definitions for all these chronic conditions, and our team or co-authors in this paper have previously published a number of studies that use these covariates with these case definitions. Our outcome variable, we look at the active TB diagnosis, which could either be microbiologically confirmed or clinical cases that met the definition set forth by the Canadian TB standards. And then we also took account of the time to the event, which we counted as the number of days between the index date and the date of any of these three events, either the development of the actual TB diagnosis, death, or date of last MSP registration. So we censored everyone who haven't developed the event at death or at date of last MSP registration, or even end of the study period. In terms of the modeling approaches, I would mention, I hope you don't mind, Jay, that I would mention extended Cox regression, because we did spend a lot of time using this approach to create our prediction model. So that's really the first model that we have explored And some of you may be familiar with this. It's a simple Cox regression that accounts for time-varying predictors, which in our case are the comorbidities and the contacts or the use of immune-suppressing drugs. It's relatively easier to fit. I'm pretty sure a lot of people have used this at some point. And it's also easier to extract predictions from that model. So that wasn't really the major issue for using the extended Cox regression. The major issue we had with this was it becomes problematic for prediction, because for those of you who are familiar with the extended Cox regression, it uses all the exposure and all the covariates for the entire time frame, even the ones that someone would only know at some point in time after baseline. So basically, it uses information that someone who would like to generate a prediction wouldn't know at the time that that person is generating the prediction. So that's the major limitation of the extended Cox regression models. And sure enough, when we were internally validating our extended Cox regression, we noticed a lot, and we compared it with a different approach. We noticed that there's quite a substantial overprediction when we use the extended Cox regression, and we attribute that primarily to the model using information that someone making a prediction at baseline wouldn't know. This is upon the advice of one of our collaborators in Quebec. We were introduced to landmark analysis, which is also a variant of Cox proportional hazard models, or the Cox regression, except that what it does is it only uses information that would be available at the point of prediction, meaning at baseline. The really interesting thing about the landmark analysis is that it uses several of those Cox model data sets. Each time, each model or each data set vary only in terms of the landmark data or the landmark time that it uses. And it sets all of the covariates at that point in time, at the landmark time. It could be any day interval. And we ran a lot of analysis looking at the different time intervals from 30 days, 60 days, 180 days, and even 360 days. But we did settle for the 180-day interval period. Basically, you construct the landmark data set by creating many of those Cox regression data set fixed at baseline at varying in terms of their landmark times, and then you stack them together to create what's called a super data set, and then you just run your analysis on that big landmark data set. In terms of internal validation, when we were developing the model, we debated on whether we will be using the traditional method of doing it, using 80% or 90% of the data for development, and then holding out 10 or 20% for testing. We ended up using the entire BC data set just because we are concerned about the small number of people that would have the outcome that we are interested in. And so we ended up using cross validations, which we performed 20 times. And we looked at whether the predictions are optimistic or pessimistic, meaning if it's over predicting or under predicting, based on the cross validation results. We also used cross-validation approach to determine what form of variable we're going to be using, whether it's continuous or categorical, or whether we should include interaction terms. And for those who are interested, what we found was that categorical variables and models with no interaction terms tend to generalize well, as can be predicted from previous work done by other statisticians on this. For external validation, we use the entire Ontario data set as our test set. The data set was supplied by our collaborators from ICES or ICES. And then we generated the discrimination and calibration indices, and we performed bootstrapping to estimate the confidence intervals around those metrics. Some of you are familiar with this already if you're doing work on risk prediction models. Discrimination is a measure of how well a model can separate individuals who will develop or will not develop the outcome of interest. And calibration indicates the agreement between the predicted risks coming from the model and the actual observed risks from the test data set. And calibration can be broken down into two metrics as well. You have the calibration in the large and calibration slope. Basically, calibration in the large measures how, on average, close the predicted risk is to the actual risk. And calibration slope, on the other hand, measures how close the predicted risk is to the actual risk across the entire spectrum of the risk prediction values. Essentially, you could think, if you think in terms of regression models, you can think of calibration in the large as the intercept in the model, and calibration slope as the slope values in your regression model. The results, in terms of the results, our cross-validation shows that the model has good discrimination. It ranges from 0.75, and the optimism, the tendency for the model to overpredict ranges from 0.005 to 0.012. So it's a very small optimism. And then the calibration in the large appeared to be close to 0, and in some cases negative. And the calibration slope is also below 1, suggesting some underfitting. And what we also found was that those models that look at longer time frames have lower reliability. So earlier we were looking at developing models for a 2-year prediction window, a 5-year prediction window, and a 10-year prediction window. And we found that from our external validation that using longer time frames, they tend to have lower reliability. So we stopped pursuing work on longer time frames. And this is our model. This is the model from BC. And something I would highlight is that the traditional covariates that people would associate with higher risk of TB are reflected in the model that we have developed in BC. So these covariates include older age, male sex, refugee status, and countries with high TB incidence, as well as those people with close contact and people that developed comorbid conditions. And this is the model metrics from our external validation results. As I've said earlier, the concordance estimate is around 0.7, both for the 2-year and the 5-year time frame. And the calibration slope is around 0.87 or 0.85. Ideally, you would want the calibration slope to be 1. So when it's 1, it means the risk predictions are perfectly calibrated, and values less than 1 suggest overfitting. And when we look at the extent to which the model overpredicts the actual risks at different time points, we notice that for the 2-year time frame, there's a slight overestimation, meaning the expected risk coming from the model is slightly higher than the actual risk. And then when we look at the 5-year time frame, we observed that there is a slight underestimation. And we also look at the ratio of the expected to the observed risks by different subgroups. And as I've said earlier, overall, there's a slight underestimation of the actual risks when we are using the shorter time frame or shorter prediction window. And then for the longer prediction window, which is 5 year, there's a slight underestimation. And the pattern that we're seeing is that generally for people with high risk, their risk is a bit overestimated by the underestimated by the model. And at this point, I'd like to walk you through the model. So we created an R-Shiny application for the model. So these are the actual variables that we have selected from our model and the ones that were validated with Ontario dataset. And this is meant to be used in real time. I mean, if you change the some of the variables, you should be able to see corresponding changes in the estimated risk. For example, someone with a person living with HIV, their estimated risk would be about 177 per 100,000 population, and within a 5-year time frame, that would be about 459 per 100,000 population. And you can change different parameters to look at or to generate different predictions. And I will stop sharing for now, and I will hand it back to Jay for the next steps regarding the model. And then we'll go into the Q&A.
Yeah, so first of all, just, I don't think we have an acknowledgement slide here, and there were like 1,000 people who worked on this with us. I want to particularly give a shout out to Hennedy Shula, who did a lot of the background work in the coding of this, and Camilla Romanowski, who's been shepherding this along and also created this website. But there's a number of people who helped create the variables, and the Ontario team led by Sarah Broad and ICS, who had to do their own database linkage in Ontario with 1 million people. And so it was a huge effort from a lot of people. So just wanted to acknowledge everyone's work on that. In terms of the next steps, so here we have a pre-screening risk prediction model. So there's a lot of post-screening risk prediction models. There's 2 websites that can show you, once you have a skin test or an IGRA, what to do with that. But this is one saying these are groups that are at high risk. And so that's really useful, because now we can actually say, okay, so which of these groups is actually cost effective to actually screen, and from a, just from a risk benefit point of view, which groups would actually, have some benefit. So we've done a little bit of preliminary modeling on this already for the Canadian TB standards, and some recommendations came out in Chapter 13 Canadian TB standards saying people from a country greater than 200 per 100,000, age less than 50, should be screened, because they would benefit in terms of, if they were positive, their risk is sufficiently large that it would exceed the risk of preventative therapy. But we're going to do much more detail. We have CHR to do much more detailed modeling with Jonathan Campbell, who used to be here, is now at McGill, assistant professor, to actually model out sort of, what groups would truly be benefit from this, which groups would be cost effective to screen, and what would the numbers look like with those groups. So we can find groups, but what if that group's 1 million people? Can we really screen 1 million people? So maybe we want to screen just, the 50,000 people with the highest risk to start with, because that's what our budget can afford. So we're going to be doing some modeling from that front on a population level to try and figure out what are our next steps in terms of practical screening. And that's kind of where we stand. Ideally, we'd also like to redo this model with more recent data and adding further variables such as TNF inhibitors and transplant. We have all that data on our side. Unfortunately, the people in Ontario don't have that data, so we're not able to validate some outcomes such as TNF inhibitors, which is really a shame. So I'd like to actually pursue that going forward, but it's a little more difficult unless we can find a place to validate. And so that's kind of our next steps. Ideally, I'm here embedded at the BCCDC, and although I don't have all the say in policy, definitely there's a provincial committee that hopefully we can bring this information to and say, okay, here's the results of our risk prediction model, here's the results of our risk benefit and our cost effectiveness and our population analyses. Who should we screen? And then ideally, 1, 2, 3 years from now, we can actually come up with a provincial policy saying, these are people we should screen upon entry. These are people we should be screening who already are here. And then also, obviously, to do that on a national level would be important as well. So those are the next steps. So welcoming any questions on this. I'm sure there's probably from some people who are more methodologically inclined, there's probably some questions about the landmark model and just questions about our approach in general.